You're watching Effective Use of Health Pathways in Clinical Practice and GP Training, produced by GP Supervision Australia and presented by Dr. Lucinda Whiteley, Dr. Aaron Kennedy, Dr. Martina Gleeson, and Dr. Justine Lancaster. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
Welcome all. I would like now to introduce our panellists. We've got two Australians, two Kiwis. Lucinda is actually from the UK, but she now lives in New Zealand, and she's the clinical lead community partnership with Streamliners Health Pathways. We've also got from the other side of the ditch, Justine Lancaster, clinical advisor, National Care Pathways Program, and regional clinical advisor for Health Pathways in New Zealand. And then two Australians here, Martina Gleeson, Clinical Lead General Practice, Southeastern Sydney Health Pathways, and Aaron, who is the GP Clinical Editor for Mackay and Darling Downs, Regional Group Clinical Advisor for Queensland, South Australia, and the NT, a pretty broad reach. But thank you so very much for joining us and look forward to a great session.
Hello everybody, and for my New Zealand colleagues, kia ora koutou. Really looking forward to talking a bit more about how health pathways can help supervisors and help GP trainees. We're going to talk a little bit about how we're using health pathways in Australia and New Zealand. We're going to talk about health pathways use for training and find out a bit more about how we're all using it. And then we're going to use a few case examples. Well, I haven't had my nature fix for the day, so this is an excuse really to show you a beautiful bit of New Zealand, the braided rivers in the South Island where I am. They remind me though of health pathways in various ways. Weaving together, one of the things that's so useful for GPs is that weaving together of the information, all the information that we need to be a GP. So it's that clinical point of care guidance or clinical decision support alongside the referral and services that we can find that our patients need that we might not know about or that keep changing, together with patient information. So lots of things weaving together. And you may not know really how they're made, I guess. So I thought it would be useful just to tell you they're really made by GPs for GPs. The clinical editors are GPs, and they are the people who go and meet with the specialists and meet with the subject matter experts and meet with the other people in your health system to review the policies and guidelines and get that evidence base into health pathways and then make it locally relevant and practical. So how things are done around here. So it gets GPs part of those discussions and influencing those discussions, and then it also makes it practical because they're the ones using it the next day as well as you guys. So, and then behind the scenes, there is a health pathways community around the world of members. There's nearly 60 members across New Zealand and Australia and parts of Britain. And last week we welcomed our first Canadian colleagues. And that has opened up the possibility of sharing pathways. So we share pathways and then we can localize them and get that information right for your local area, but it can make it more efficient and we can do things quicker. So, and then Streamliners hosts the platform and the writers that work with the clinical editors. And Streamliners is part owned by Health New Zealand, Te Whara Ora, and part by a soon-to-be charitable trust called Just Trust. And then the programs in Australia are funded and supported by a mix or a collaboration between the state services and the Commonwealth-funded PHN. So it's a bit of a mix in different areas. The model's different. In New Zealand, it's Te Whara Ora Health New Zealand. So lots of people behind the scenes involved with bringing it to you. I thought I'd really just mention that there is a hospital health pathways, because unless you're in Hunter, New England, you might not know about it if you're in Australia. And there's a couple of hospital health pathways in New Zealand and a few in Britain, but the rest of this talk is going to be about community health pathways, but they're aligned and it can be very useful for that flow of information and patients and consistency between hospital and community. And I just thought you might be interested to know of its existence, really. I thought this one was interesting. It's the number of sessions in the last 90 days per 1,000 people in the population, just to show what a large variation there is. And we give registrars a list of resources, and then we probably make presumptions about what they're using and indeed what our colleagues are using. And, you could be wrong, because there are areas it's really highly used, but in some areas not so much. So there's a big variation. And this is a similar graph for New Zealand and Canterbury, which is the oldest program. That's where I'm based, actually. And I wanted to show you this because, well, I'm part of the cohort that only ever practiced with Health Pathways. It was in my GP registrar year onwards. It was the resource. Our trainers all used it with us. And people who use it tend to get value from it. They keep using it and they tell their colleagues. So I think, we would expect in the areas where people are getting value from it, they keep using it. We want our registrars, we want them to have this tool so that they can take it to other places they're practicing in. And really, rather than just teaching them knowledge, we're trying to teach them the processes of how to learn, and that they can take this somewhere else and use it in their consults. So just talking a little bit more about using it for training. Some of you will have seen this one, and I think what I wanted to convey from this one is that we're all in different parts of this cycle throughout our career, from the unconscious incompetence, starting to get into that conscious incompetence, knowing what we don't know, then starting to get a bit skilled, the conscious competence, then maybe a little bit cocky, or things change, things evolve. And not only do we change on this cycle through our career, but even for a specific area. I mean, we've all got areas of expertise and areas we don't know so much about. And it's so easy to think, something, I'm just about getting old enough that I think I know things. And in fact, it was 10 years ago since I've looked it up. And we rest on our laurels and things have moved on. So we need tools, not just Health Pathways, but tools that we know that our registrars are using and that we know we're using, because there's just so much breadth of stuff we need to know, isn't there? We can't keep up. And I'm going to hand on to Martina.
Hi, everyone. I want to let you know that there are different types of pathways. And they roughly fall into these three categories. So the ones that people think of when they think of health pathways are the clinical pathways, which show the assessment and management and referral of either a condition or a presentation. So you might have a condition, say atrial fibrillation, or you might have a presentation like cough in palliative care, where it's an undifferentiated condition that you need to work out what it is. They're designed to be used at point of care, and we try to keep them leans in the majority of cases so that you can drop in, quickly find what the bit that you need, and then keep going with your consultation. Request pathways identify our local and regional referral and advice sources when the GP needs help. And resource pages don't have the same structure as a clinical pathway, but they're developed to augment the clinical pathways. So an example of that would be medications in osteoporosis, or medications in depression and anxiety, infection control, that sort of thing, where you need information, but it's not actually a clinical presentation.
Can I ask a question, Martina? Because I know there'll be a lot of supervisors listening. One of the ways that we really emphasise for registrars to develop illness scripts and their learning is to be presentation-based. Here's a patient with a cough, let's generate a differential. Here's a patient with a headache, let's think about a differential. Can I just ask, with Health Pathways, it's interesting because I think most of us would think about it as being condition-based, but you say there are presentations. How comprehensive are they, and are they certainly more condition-based than presentation-based?
Safe to say that there probably are more conditions than presentations.
Yep.
Presentations are actually quite difficult to write a pathway for because they're undifferentiated. We've just taken headache in adults live in southeastern Sydney, so that's an example of a presentation. we're working on eye problems in children. That's become a behemoth of a pathway because there's so many different eye problems in children, right? And we've had to do that as a response to the statewide referral criteria for ophthalmology that have been released in New South Wales. So yeah, you will find some undifferentiated presentations, but then you will also find conditions where usually the clinician has got a gut feeling of what it is.
Thanks.
And then they want to know how to assess it and confirm the diagnosis, what investigations or do they need to do to confirm what they think is going on. So both of them can be helpful. I just wanted to demonstrate that we have our request pages separate to the clinical pathways because you can have a one request page, like one group of services that you're requesting for your patient that are relevant to a whole lot of pathways. And if we have that one page, then we've only got one place that we need to change the information on if the information changes, like if the criteria for your local gastroenterology outpatients changes or the contact details for who you call to get advice changes. We only need to put that in one place, and then all of the pathways that link to that request page can be maintained rather than scratching your head and trying to remember where did we put this information, which clinical pathway does it live on. And I just want to explain also that we use request rather than referral because that is the philosophy that bases the patient and the doctor in the centre of the team. And we are helping our patient negotiate the system and requesting additional services as they are needed. Whereas referral seems to imply that you're passing the patient on, handing them over, not necessarily expecting to get them back. So that philosophy is we're at the centre of care together. Requesting services in is what we're basing a lot of the work that we do. And just to point out, there are certain components of a clinical pathway that will always be there, and they're the primary elements. So assessment, management, request. And then down the bottom, you'll also find information, and you'll have often two sections, information for health professionals and information for patients. So that can be really helpful if you want to find a handout or a website for a patient to back up what you've done during the consultation. And there's always a feedback button so that if you see any inaccuracy or a broken link, you can press that feedback button and that will email the team and we will receive that feedback and act on it. There are additional elements that you can see on some pathways, and so you might have a scope statement to limit what the pathway is about. You might have red flags, and in health pathways, red flags are not who do I send to hospital. They are more, these are conditions that I need to be aware of that it's very important that I don't miss because it's a clinical risk. You might have some background, and in that background, you might find some definitions and some epidemiology, and that can be helpful for your registrar to know that background, but it's often like it's nested in background because it's not essential for managing the patient right now, but it is helpful to expand your understanding of the condition. Key links might be to documents that you need to access or that back up the pathway. So when we were writing the COVID pathways, we had key links to, say, the ACI guide for managing COVID in the community. A practice point might be a specific thing that you need to remember to do, and a clinical editor note is used to update information that we need to do right now, but the pathway isn't ready for review yet, so we just add a little bit of an extra note up the top. And back to you, Lucinda.
I guess we're interested in how we can encourage people to really reflect on what they're learning on health pathways and what they're using. From later this week, actually, for people who have a health pathways account, and that's something that's being rolled out gradually, there'll be a CPD reporting tool. You can click on your history and it will take you through to where you can add reflection notes on what you've learned or how it might change your practice. So I think that could be pretty useful to go through in supervision time, that kind of thing with your registrars, and also help to almost, I know they don't need to report CPD at the beginning, but to get used to using it as a reflective tool and knowing that that's what they could do going forward. And for the record, your personal usage data won't be shared with anybody other than you. So that's not shared with whoever's paying for your local Health Pathways program, just to let you know. So yeah, that's kind of exciting. And if you prefer paper, or if you're in an area that doesn't have a Health Pathways account yet, my colleagues in Darling Downs also work with the colleges on these reflective learning templates. And in lots of areas around Australia, there's a page called CPD Hours for Health Pathways, and you can use these as well. I'd also encourage you, I think it's a great way to do audits, being able to pick out a few things within the pathway and look and see whether you followed it, or which bits you have or which bits you haven't. So I think that's another good thing to do yourself, but also to mention to your registrars if they're looking for what kinds of audits they're wanting to do.
We don't require in Australian general practice training registrars to complete quality improvement activities like audits. It used to be that a project was part of their training, but not anymore. I mean, I know a lot of supervisors do encourage that, but I think you've made an excellent point, and this really can be the basis of something where a registrar working in your practice can contribute to better functioning of the practice, better health outcomes for a population. So it's a great spot, I think, as you say, to go to say that. And I think that's absolutely, even though it's not required, it's absolutely reasonable that supervisors suggest to registrars to do that as part of the QI for the practice.
Yeah, and I think it's part of training and learning how to do an audit, because suddenly you're an independent GP and you may not have really done them before, or may not have done them independently without sort of someone in the hospital helping you. So I feel like even if it's not a requirement, it's a great habit to get into building experience in. So yeah, I totally agree. Simon?
One of the comments in the chat was that a person has trouble finding what they're looking for. We are actually about to launch a smart chat function, which should make it easier for people to find what they're looking for in the health pathway. Hopefully that will make them more accessible. There's also a little bit of a trick if you're in a pathway and you're looking for something and you can't find it. If you go over to the side and you click expand all, and then you use a Microsoft function, which is Control F, which is find, and then you type in the term you're looking for, it'll highlight where it is in the pathway. So that can be helpful when you're looking for something specific in a pathway. These are a few user case examples, and I tried to think of things that you wouldn't necessarily think Health Pathways would be helpful for. Here's one where a new patient arrives to your surgery, and she's the mother of one of your male patients from Iran. She does not speak English and you don't speak her language. So did you know that you can use Health Pathways to assist you with this patient? So this might be your registrar who comes in and says, I've got a patient who doesn't speak English. She's here with her son. I kind of remember I'm not supposed to use family members to be a translator, but I don't know how to access translator services from inside the community. I've only ever done it through the hospital and got the ward clerk to book them. So there is actually a health pathway that's available in most regions called interpreter services. You can see in the screenshot here, I've just started typing in the top chat, and I haven't even got to the end of interpreter, and it's actually INTERP, and it's given me that link to the pathway, so I've been able to click on it. And that's what we would call a resource page. You can see there's no assessment management and request part of it, but more when to use it, using it, and then services that are available for primary care providers and private specialists. So you can use that to access and interpret a service. And you're not going to find that on therapeutic guidelines. Another case example, something that you don't do every day. It's been a long time since you've scheduled a patient, but today your registrar needs your help. Use Health Pathways to help you find the forms and call for help. And so if you search on Health Pathways for scheduling a patient, again, most Health Pathways will have that pathway available, which helps you assess whether the patient meets the criteria for being scheduled, and then how to go through the process in your state. And each state has a slightly different process. So it's really important for you to have locally relevant information with links to the forms you need and the phone numbers for who you need to call. And so hopefully you and your registrar can work together to organise that in a very busy day, and having access to the information might make it that it's just not quite as bad for you as might otherwise be, because you've got early access to the information. I think the next one is For you, Aaron?
The case I wanted to present was, I chose this case because it's actually an old case that happened about 10 years ago when I first got involved with Health Pathways. And it was really one of my first interactions with Health Pathways, both as a clinician and also supervising a registrar. So it stuck in my memory because it had been so useful at the time. And it's also a useful case because there's very little clinical detail to go through, so it doesn't take a lot of going through it. But there was a number of important questions that were raised. I repeated this diagram from Lucinda because for me it raised the issue of, for my registrar was unconscious of the stuff that they didn't know. They came to me with a question that was quite simple, was around the examination of a patient. But my mind was immediately going to, I think this patient really needs something important, probably needs it quickly, and I couldn't put my finger on it because it wasn't a common presentation. So I was working in, at that time, a GP-led, what we now call urgent care clinic, but in the days before they really existed, it was a GP cooperative in our regional area. And this was a patient who's otherwise well, completely boring history-wise, and completely boring examination-wise, but just comes in and says he's had a nearly complete loss of hearing in one ear. So clear ear canal. Things were pointing towards this being a unilateral sensory neural hearing loss. The question that my registrar brought to me was, he just wanted to know where the tuning forks were so he could complete a hearing examination, and had some questions because it had been a while since he had done them, how to interpret the Weber and Rene test. And to be honest, it had been a while since I'd done it. So while we were scouring the clinic for the missing tuning forks, I'd recently been told about Health Pathways. And I said, oh, let's jump onto this new thing and let's see what it says. So I'm using different sites from around the community for this to try and replicate what it was like 10 years ago. So as you can see, these are just screenshots from the site. Typed in hearing, and it comes up with a suggested page of hearing loss in adults. That sounded about what we were after. Navigating to that page, it looked like this. This is what we call an unlocalized page looks like. So one of the processes, as Lucinda was saying earlier, we have GP clinical editors in your local region who go through pathways and make sure that they're applicable to your local context so that they match the services that you have available and the resources that you have available, and that there's agreement between what we're doing in general practice and what our local specialists would be having an expectation of in management. That yellow background indicated that it was not localized at that time. The reason I still use this case is because the clinical information, despite it not being localized, was still relevant. The first question the registrar had was answered quite easily, just scrolling through the assessment section. There's these drop boxes, one for Weber test and one for any test. So we quickly opened those, reminded ourselves of which test was which, how they were done and how they were interpreted. So the registrar was then able to go back to the patient feeling confident that they could do the test properly and they could interpret it correctly. But my mind had gone on a few steps further. I was worried about this patient. I had a few questions. I was pretty sure they needed an urgent investigation. They needed audiology, hearing test. I thought they probably might need an MRI, which was going to be hard to get where we were situated at that time. I thought I had a vague recollection of there was an urgent management decision to be made around steroids. I needed to know dose, how long, could it be delayed or should it be started? Had that changed recently? I needed to know that kind of information. But I also knew that I'd need an urgent referral, which is difficult for an ENT problem in a regional area. So going further down into the pathway, that top circle, I can click on urgent audiometry and it will take me to my local audiology services. I could quickly see that, yes, prednisolone was the appropriate, steroids are the appropriate treatment. We don't include a whole lot of information. It gets the patient started, but I had enough information to let the patient know this is the standard treatment. We don't know how well it works, but it may bring back some of your hearing. So if I click on that request link, This is now taking me back into the page that I was using, and all our request pages have been localized, so it's local information. I've got a phone number. This top one, Attune Hearing, were across the road from me. I phoned them up. I said, I've got a patient who's sudden hearing loss. I need an urgent hearing test. And they just said, send them straight across the road. We'll do it now. So while he was across the road, I can then click on ENT advice. You can see that in the table of contents there. Gave me the phone numbers for both public and private services that I have locally. For where I was, that meant there wasn't really a public service. I did have a phone number for a surgical registrar at the local hospital, but that wasn't really going to help me answer the question that I needed for my patient. So I could scroll through to the local private ENT specialist, phoned him up. He said, yes, definitely start the steroids. He needs an MRI. And I said, that's going to be expensive. This patient's already worried about the cost that he's incurring. He said, no worries, I'll fax you the MRI. He sent the MRI request form to me. So that by the time he came back from his hearing test, I had his MRI booked. As soon as he had his MRI, he could turn up to the ENT specialist for his follow-up. So all of that happened within about a half-hour period. And my experience is these are the cases that often chew into your day. There are a number of questions that needed to be answered. And if I'm having to jump around to try and find that information, it can really waste a lot of time. Patient was super happy, I was happy, and the registrar was happy. Obviously, though, it's better if that pathway was localized, and that's what we do as GP clinical editors, because there can be other issues in that management, which I can then go back through at the end of the day. I can catch up with the registrar and say, hey, let's go through the rest of that pathway. What if this patient had chronic hearing loss? What would be different? What would be our response if they had a commercial driver's license? What are our local rules around that? We put in the pathways all the links, direct links, so that instead of me having to go through Oz roads and try and find that information myself, it will take it directly to the page about hearing loss and what are the relevant rules around that. Patient information sheet that's localized either, hopefully, to my area, if not my area, to my state, if not my state, at least to Australia. So I know I'm giving them information that's going to be up to date, curated by fellow GPs, and at my fingertips so that I can access that really quickly. So I think that was all I was going to say on that case quite quickly.
Thanks, Aaron.
But there was a comment about cookie cutting medicine and how, I guess, there's the tension between being an independent, autonomous thinking GP and following some recipe book. I might allow you, Justine, to talk initially about, your experience as a supervisor and in training and things, but I think it would be nice to come back to that too, because I'm detecting a little bit of maybe negativity around that sort of following the bouncing ball. So Justine.
Kia ora koutou, and thank you for the opportunity. Most of you won't know me, but I'm a practicing GP as well in Wellington in New Zealand, and have been a GP medical educator, particularly doing the in-practice visits for the Royal New Zealand College of GPs. And I'm also a New Zealand clinical advisor for Health Pathways, the same as Aaron and Martina. But yeah, cookie cutter has been an oft used criticism of the Health Pathways concept from people who have never really used it very much. And my answer to that really is Health Pathways isn't there to tell you how to do your job if you know your job, but beware and teach your registrars to beware of what they don't know on that cycle of learning. It really can be very effective as a little bit of a reflective tool, checklist, safety net, particularly for the learning GPs. The ones that, often our GP trainees are only in their third year postgraduate or fourth year postgraduate. There's a lot of clinical experience they haven't had and a lot of knowledge gaps. So it can be really useful when you're reflecting on a consult with a registrar to probe a little bit about what might have made them feel uncomfortable. Were they aware of any deficiencies in that consultation, and then getting them to double check their consult against what there is in the pathway just to see if there's any aha moments in there for them. Usually it's very reassuring for everybody, but it can be a very useful tool for just helping everybody have a little bit more confidence that they haven't missed something in the rush of the moment and the pressure of an emotionally intense consult or something. People new to general practice, there are a lot of things we forget they really don't know. One of them in particular is the access to really good patient information. Like, our patients crave really good diagrams or good simple explanations that they can take home with them, or links to great websites. And the Health Pathways is a treasure trove of that in the information section. And the other treasure that's in that information section is that in-depth learning that the registrar is craving, because many of them really don't know a thing about ophthalmology or gynecology or even pediatrics half the time. So in that information section for health professionals is usually a very well curated list of the best of as your key resources to learn more about this condition. So as an in-practice visitor, I'm often probing in that reflections point with my registrars. What did you not feel comfortable about? What would be your next steps for learning? What would you have done differently? And the Health Pathway is a really useful place to kind of guide them with some answers to those questions.
I'm just thinking of the parallels between kind of sometimes stumbling through an explanation with a patient on a condition that you may not be overly familiar with, using a resource that similarly a supervisor can use the pathway to frame a discussion about the condition and investigations and management and things. And as you say, I think registrars reading it, seeing it written with evidence might be more powerful learning than just a supervisor say, oh, next time, use some prednisone.
And they can look back at it as well, and double check. The other thing is that many of our registrars, not only are they brand new to general practice, but they're often brand new to the local health system as well. They don't have those relationships. They don't know the key specialists or how that hospital organises its departments and which one to refer your cellulitis of the leg to, And the pathways are really valuable for showing you how we do things around here, what our local referral criteria are. But the pathway itself is designed to be read as the process that the GP needs to think through. The clinical editors are active GPs. Martina, Aaron, and I have all been clinical editors, so we know we're constantly trying to get the information in there that reflects how a GP needs to work up the clinical problem, which is often very different from other information resources. Interestingly, the College of GPs in New Zealand have embedded Health Pathways in their training. Often it's used in their examples. It's recommended in their exam prep, particularly for the OSCEs, just because of the way it's designed to be the GP process, the way that the GP works up a undifferentiated problem or manages a long-term condition. It's very much embedded in how we teach here.
That's a very interesting reflection. It's very different here, I think, and maybe that speaks a little bit to why the uptake in the two countries is significantly different. If training GPs and new GPs and early career GPs are exposed to it so much as part of their training, they study with it, then it's likely they're going to use it more as a clinical tool.
Yeah, that's right. One of my medical educator colleagues who also works in Health Pathways for a specific small region in New Zealand has a very high uptake compared to other similar regions in New Zealand of users, and that's probably in part due to every registrar she visits. Her takeaway message for them is to copy and paste the link to their local Health Pathways site and bookmark it on their phone, saving the login on their phone, so it's not actually attached only to their clinical workplace, but as a website that they can go to on their own private device, no matter where they're working, where they're going. And that's been a valued piece of information because they continue to use it.
That's a great tip.
Anna, can I just address a couple of themes that are emerging? There's one that I think you could safely say expressing dissatisfaction with the variations of clinical priority criteria that are set by public hospital outpatients. And Queensland has got the clinical priority criteria, and New South Wales has the statewide referral criteria. I think Victoria has a version, and I'm not sure, does South Australia as well. And it can be very frustrating for referrers because some of the required information seems to be quite arbitrary, and the referrals are sometimes rejected because a minor detail is not included. And people are frustrated because Health Pathways hosts that information. I just want to be clear that we don't make it up. It's hosted on Health Pathways because it's been set by the state government, and it's to try and actually help people who have decided to refer to an outpatients department to know that they're including the information that is going to be needed for that referral to be triaged. But sometimes you'll find a variation between what is recommended in the clinical pathway and what will be seen in the outpatients department. And that's because the clinical pathway is what should be done, and the outpatient department is what the resources will provide. And if the resources won't provide them in the public system, then we still recommend that you do it. It just means you won't be able to do it in the public system. So you might find a difference with that one. So don't shoot the messenger.
So Martina,
Yeah,
the other thing for me as an editor is when I'm writing Pathways, my focus is on this is maximizing what we do as GPs.
Yes.
That the pathway is not about the outpatient. There's become a big focus on the SRCs and CPCs and all those things. For me, that's a minor part of patient care. It's kind of an endpoint of needing a referral. What I need to know as a GP is what can I do for my patient? What's the appropriate management that I can do that doesn't even involve anyone else? Everybody's got criteria. I see these people, but I don't see these people. And what we're trying to do is document that so it's transparent about which services are available for the patient that I'm in front of now.
There was a really important question about what do you do if the registrar says you're wrong because it disagrees with the health pathway?
I've got to comment on that. One of the things that's, I think we work in a complicated field. It's constantly changing, whether it's the medicine itself is changing because there's been updates, or the services or the system is constantly in flux. And, we experienced that at a high level during COVID when everything was changing every Friday afternoon. What we're trying to do in Health, it shouldn't come as a surprise for us as clinicians that a registrar says to us, oh, I read something different on Health Pathways, because we're aiming for the Health Pathways to be as up to date as we possibly can. They're going to be more up to date than the, guidance that, the big guideline that gets updated every 10 years. That's not soon enough. Medicine is evolving far quicker than that. So if your registrar says, oh, I read something different on Health Pathways, that's a great opportunity to say, oh, show me. Let's have a chat about that. Oh, I didn't know that. That's really good to know. That's changed since a year ago. That's new evidence. Let's have a look at that. Let's discuss that. Let's get the other team members in because they also need to know about that. Being able to shorten the time from sort of research and get that into practice is really important. And I think that's one of the things that we can achieve in Health Pathways. We haven't mentioned it very much, but if you know something has changed as a supervisor, you can press feedback and get in contact with your local team and say, there's a new resource, there's a new guidance, there's a new drug, there's a new phone number, whatever it is. That's useful information that we can then share with your colleagues in the rest of your region.
Thank you. I think that's a point really well made, Aaron. What we like to say to the supervisors through GPSA often is that registrars often do have more knowledge than the supervisors in the field. They're going to workshops all the time. They're reading, they're studying for exams. But our strength is how to apply that knowledge. It's about how to put that into context with the patient in front of them. And that's where I think Health Pathways can be valuable. It needs to be totally contextualised who you're looking after. But maybe just last pearls, tips, encouragements, and then we'll wrap up.
I think my pearl is really that it's more than clinical pathways. And I think the more experience we get, if we're reflective learners, the more we realise we can't keep abreast of everything. And so even if you think you know about something, sometimes it's worthwhile checking that pathway to make sure that what you believe to be true is still up to date. It's also helpful if you've been to a webinar and you've heard an update and then you come across the clinical presentation and you might think, I seem to recall there was a change in that, to sort of reinforce the learning that you did by referring to the health pathway. And you can teach that to your registrars as well, that they can use health pathways to back up what they learned when they went to a teaching session. My tip would be actually watch what resources your registrar is using and use it with them. And that may be health pathways, but if they're using something else, what are they using? Why are they using it? And if they are using health pathways, how are they using it? We just give people a list otherwise, and we don't know what they're doing. And I think the most important thing is that people are using something for good quality care. And I think health pathways is really good for that, but we need them to be using something. So watch them.
A thought I had was, we've been talking about community health pathways, and for me that's got two meanings. One is that pathways are about important work that we do in community health with our patients, but it's also, we are part of a community of GPs and we can all be contributing to each other's knowledge. So I'd encourage you to be an active part of the community. Don't just be a passive, recipient of, here's some health pathways. You can get involved, hit the feedback button. If there's a resource that you expected to see there or a question that you didn't get answered, take the time to put the feedback through so we can add it, so that it's then available for next time you need it, or for your colleagues as well. So yeah, get involved in part of the community.
Thank you. I think it's interesting when Lucinda and I were talking about pulling this together, it was really, well, there's this resource and, some people know it, some people don't. How can we explore? And I think those last comments around it being far more than just a clinical algorithm, that it has this really, really important role as a teaching tool. I really love that notion of it. When we see community health pathways, Aaron, that we think of ourselves as part of something a bit broader than just ourselves in the consultation room. And yeah, that curiosity and exploration and always trying to strive to improve our knowledge, I think they're lovely messages to take away. So thank you so very much. This will change my practice, I think, as an educator, as a clinician. I will explore the resource more fully than I have, and I hope others have taken that away to some degree. Encourage use in your registrars, encourage use in your practice colleagues. And as Aaron says really well, feed into the process. You don't have to be a clinical editor, but you can make suggestions and comments. Thank you so very much, team. It's been fabulous. All the best. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.